Good evening to all the respected dignitaries. Myself, Dr. Neha Singh, and I welcome all of you for today's webinar on behalf of IIP Raigad. And today's topic is a pediatric airway problem in routine OPD, ENT perspective. And first, I would like to welcome our IIP Raigad President, Dr. Vikas More sir, to please welcome our guest and expert, Dr. Anju Chaudhary ma'am.
Uh, Good evening, all of you. I am Dr. Vikas Mori from IIP Raigad. I welcome all of you for this unique CME of difficult airway disease. And we are very excited to have Dr. Anju Chaudhary to guide us for this very different topic because we know that as a general pediatricians, the children have a different airway as compared to adults. There are many aspects like in a small children there is a different anatomy, there is a different physiology, and I personally feel that the patient factor, then the in the clinical settings where you are sitting, and the experience of a practitioner really contributes a lot when you are handling a pediatric airway. So there are many uh, aspects of a pediatric airway. For example, if I say that prominent occiput due to which child always flexes the neck, so it becomes difficult to assess the airway, the large tongue, the more proximal larynx. There are many factors which actually make the child airway slightly tricky as compared to adults. So we know that the pediatric pulmonology has come in a very big way, and we have forgotten our ENT colleagues who also handle pediatric airway in a very with a very different approach. So we wanted to have their perspective, how they manage the pediatric airway. So it will be really good learning for all of us. I'm very excited. I see that many dignitaries have joined the today's webinar. I saw the Dr. Divya Prabhat also had joined. It is honor for all of us. Uh, I'm very eager to hear this upcoming CME. And now I request our own Dr. Parvesh Singh to continue the further proceedings.
Thank you, sir. Am I audible, sir?
Yeah, you're audible.
Yeah. Thank you, sir. It's my privilege to introduce Dr. Anju Chaudhary. She's a very good friend of mine. But at the same time, she's a very good, passionate consultant airway surgeon. She is a consultant at present at Saifi Hospital, SRCC Children's Hospital, Wokhad, Global Hospital, and at Borivali Healthcare Center. Her area of interests are laryngotracheal reconstructive surgery, both adult as well as the pediatrics. I'm like very glad to say that she's a gold medalist in ENT from TN Medical College, Nair Hospital. She has acquired extensive practical knowledge and hands-on knowledge in laryngotracheal surgery, did fellowship in Prince Ali Khan Hospital, and gained international experience in Cincinnati Children's Hospital from Ohio, USA. She's been faculty at various national, international conferences and has innumerable papers on her name. So I just request Dr. Anju Chaudhary to please present with the presentation.
Thank you so much, Dr. Parvesh Sheikh, a very dear friend of mine and IIP Raigad. It's actually an honor for me to be presenting in front of esteemed pediatricians all over Maharashtra. My presentation, I would like to share my screen first and let me know if I'm visible to everyone.
Visible, madam.
Okay. So I'll just start. So my topic for today is pediatric airway problems in routine pediatric OPD, but from an ENT perspective. So I'll try to keep it more clinical, not theoretical, and I'll welcome questions maybe intermittently or at the end of the session. I would first say that I'm an ENT surgeon, but I practice at those two places, Saifi Hospital and SRCC Children's Hospital, mainly under the mentorship of Professor Philip Monier from Switzerland, who is a known name in pediatric airway surgery, and Professor KK Ezi. We have established a unique department of airway surgery in both these hospitals. So it's a new branch that is coming up in ENT. We don't usually deal with these ear, nose problems, but mainly the laryngotracheal reconstructive surgeries that are part of my expertise. So as we all know that the airway does not start with just the larynx and trachea. It actually starts with the nose. When the air goes behind into the larynx, and then the lower tract, it ends in the lung at the level of the bronchi. So any obstruction at any of these levels will produce some kind of sound and then result in some symptoms. So common problems which come to the OPD with noise, with children with noisy breathing or stridor can be divided based on their age as neonates and children and various levels of obstruction. Nasopharyngeals, we can include neonatal rhinitis, choanal atresia. I'll be talking in detail about those highlighted points. In children, it can be allergic rhinitis or now very commonly seen adenotonsillar hypertrophy or some foreign bodies. At the laryngeal level, most commonly seen is laryngomalacia in the neonates, followed by subglottic stenosis and cord palsies. In children, we have more infective pathologies and foreign bodies. At the tracheal side, it's mostly bronchial malacia or stenotic lesions and always foreign bodies. So I'll divide my presentation in this flow. First, I'll deal with upper problems like nasal pathologies commonly seen choanal atresia. Then we go down to tonsil adenoids, then laryngotracheal pathologies with children presenting with stridor. And in the end, Dr. Parvez asked me to talk about children presenting with tracheostomies because sometimes they come to pediatricians for basic care. So a few points about them. So nasal pathologies, one which is seen commonly by pediatricians, I would say, would be choanal atresia. It's not very common, but because you deal with these newborn babies, you will see that it is present in one in 5,000 to 7,000 live births, with girls being more common. It's usually associated with Chad syndrome. And there are types. There, it's based on the CT picture and endoscopic picture. It's bony, membranous, or mixed. So here in this, I can say that this is thick bony stenosis. Well, this is a thin bony stenosis of one-sided. On the scan, we can correlate that this thick whitish bone is obstructing this nostril, while this is open on the other side. Here, there is a thin membranous stenosis, while there is no bony stenosis. This is important in our surgical management. Now, the important part in this is bilateral choanal atresia, which you will see immediately after birth. So, before calling an ENT or airway person, you will be the first person to diagnose it. These children will present with complete nasal obstructions on both sides. And when you try to pass a 6 French catheter through both the nostrils, it usually passes the first 3 centimeter, but we feel a block after that. Now, this child will present with immediate respiratory distress at birth and potential for asphyxia cyanosis. But the typical presentation would be when the child cries and he opens the mouth, the obstruction gets relieved. This is exactly opposite to laryngomalacias. Hence, we need to check this at birth. When the child cries, there is air passage through the mouth and the nose obstruction is irrelevant to this child. So as a clinician, our main aim has to be to keep the child orally open. How we check it? By passing this catheter here and also by using this basic instrument that everybody has in their clinic, which is the tongue depressor. We see absent of air blast as in the neonate. Investigation of choice is CT scan, which anyone can advise, even the pediatricians can advise. It can be done immediately. The differential diagnosis which we get on these CT scans is important to us as ENT surgeons for the management. It can be congenital nasal pyriform aperture syndrome. It's something similar to choanal atresia, but it is quite anterior, where the maxillary crest is closer. So the catheter that we try to pass does not cross 1 centimeter mark. So it's an anterior nasal obstruction rather than a posterior choanal obstruction. Other DDs can be a deviated nasal septum or a septal fracture during vaginal delivery. Sometimes children can be born with nasolacrimal duct cyst, unilateral or bilateral. These also can result in similar problems of passing a catheter behind. So CT scan will help to rule out all these pathologies. The immediate management, as I said, should be that we should be able to make the child breathe through the mouth. So there's this McGovern nipple, or a very easy thing to make any nipple which we can cut and tie it around the patient's mouth. The patient will be able to breathe temporarily through the oral cavity. So this will tide away the immediate crisis. You can also use a oropharyngeal airway, and of course, intubation may be needed. Sometimes, if there are associated congenital upper airway anomalies or facial malformations, and intubation is difficult, then they may need immediate tracheostomy. Now, definitive management 100% has to be surgical. Nowadays, with advanced endoscopic instruments, we do it transnasally with or without stenting. Initially, it was being done transpalatal, but it's not needed because now we have pediatric endoscopes, and we use these small ear microscopic instruments to go into that neonatal lows, because sometimes they are low birth weight. So we use really tiny instruments. We pass an endoscope and try to drill out the bone with a burr, or we can use micro instruments to just punch this bone out and give a wide airway. We may or may not use these stents. In our practice, we generally tend to use stents and teach them how to suction it. Now, unilateral choanal atresia is not actually a surgical emergency, because the child is still breathing through one of the nostril. But sometimes, if the other nostril is obstructed with some discharge, then it may present with some respiratory distress. But definitely, they will have some breathing difficulty, feeding difficulty, because they are too small and they are obligate nasal breathers. They may also present with failure to thrive. Again, diagnosis is by CT and then doing an endoscopy. In this, again, an endoscopic nasal repair will give good relief. And age here is not a criteria, because it's not a emergency. Sometimes it remains undiagnosed and the child outgrows this problem as well. But they may present with a unilateral nasal discharge or one-sided sinusitis in a later stage of life. Then we move down to tonsils and adenoids. I'm very sure that this is a common problem in all your OPDs. Symptoms, we all know that it is recurrent sore throat, fever, frequent cough, cold. Now, important symptoms that are coming, I believe after COVID, these symptoms have increased a lot. This is snoring and mouth breathing. And if the disease is left untreated, then it also leads to apneic spells at night, where parents do say that the child doesn't breathe comfortably, is quite restless, and has also not gained weight over a few years of time. So if you hear this sound, this child is breathing with his mouth open. He's struggling to breathe. There's this upper airway obstructive sound, and he's quite restless at night. So this is the typical presentations that we get these patients. There are certain associated symptoms when this child is referred by a pediatrician to us. We also ask them positive history of ear infections, because this would indicate that the adenoids are compressing the eustachian tube opening and causing recurrent ear infections, or maybe hearing issues as well. Daytime sleepiness is a very important question to be asked by all clinicians to the parents, because this will indicate a poor quality of nighttime sleep. This will eventually lead to hyperactivity of the child. He'll remain irritable in the daytime because he's not slept well. He'll have some failure to thrive. Teachers may start complaining of scholastic backwardness. So these are questions which the parents will not come forward to unless we specifically ask them. In very severe cases, they may present with cardiac issues and pulmonary hypertension as well. When we see these patients and examine them, first we have to see the size of the tonsils, which will indicate we have a grading for tonsillar enlargement. We have to check for both-sided jugular digastric nodes, whether the child has an open mouth with an adenoid facies, which is this typical look of this picture that is shown, with drooling of saliva, protruding teeth, high arch palate, crowding of teeth, everted upper lips. All are features of adenoid facies suggestive of chronic nasal obstruction and mouth breathing. Dental anomalies are certain things that the patient go to the dentist first, and the dental people find out that this is the problem. You have an high arched palate. You may have increased adenoids and then they get the X-ray done and sent to us. So there can be a reverse referral to us as well. And the pediatricians have to be aware that this can also be a presenting feature. So when we examine this patient, the oral cavity seems like this. The grade 1 means the tonsils are just coming out of the anterior pillars on both sides. Grade 2 is causing 50% of the obstruction. Grade 3 is more than 50%. And grade 4 is nearly touching each other, where there is hardly any airspace. If we see a CT or X-ray of this patient and we see endoscopically, if we correlate, grade 1 is when the choana is almost 20% less than 25% obstructed. When it's about 50% obstructed, it's grade 2. When 50 to 75% is obstructed, it is grade 3. And when there is near total obstruction, then it is grade 4. So we assess the severity of tonsillar enlargement based on these criteria. Then we talk about treatment. So we all have been giving medical treatment to these adenoid patients in terms of intranasal corticosteroids, but the recommended dose is for 6 weeks along with Montelukast treatment, because allergies are known to cause these hypertrophies, and intranasal corticosteroid by various studies have proven to reduce the size of the adenoids. Using this form of treatment can sometimes alleviate the need for surgery. The second thing is, of course, surgery. But do all our patients with increased tonsils and adenoids, all patients who are snorers, do they need surgery? So there are certain clinical guidelines that have come up, clinical practice guidelines in 2019 for tonsillectomy. It recommends that any child with 7 episodes of the sore throat per year, or 5 episodes per year for 2 years, or 3 episodes per year for 3 years is a good candidate for tonsillectomy. Also, if the child presents with one single episode of peritonsillar abscess or has history of multiple antibiotic allergies, recurrent pharyngitis, or also adenitis, these are then we do not look at these recurrent episodes criteria. We can move on to do a tonsillectomy. Nowadays, obstructive sleep apnea is coming up as one of the major criteria for doing these surgeries, which is also the case in adenoidectomy. There's a different study guidelines for adenoidectomy. For children who are presenting with recurrent purulent rhinorrhea or recurrent rhinosinusitis or otitis media with effusion for over a period of 3 months, and who have sleep disturbances, are also good candidates for adenoidectomy. Of course, cardiopulmonary complications like cor pulmonale, right, upper airway obstructions leading to right ventricular hypertrophy, these are definitive criteria for surgery. Now, dental malocclusions and orofacial growth anomalies is also one of the included criteria. So now if we look at only tonsil adenoid, it's not an infective disease just now. We treat it as an obstructive sleep apnea syndrome in younger children. To diagnose obstructive sleep apnea, only clinical examination is not sufficient. We need certain special tests, which are these two, that is the sleep study and drug-induced sleep endoscopy. So sleep study is a study done overnight where the child is admitted. This is generally done in cases where the criteria are not met, but we significantly feel that the child will improve after the surgery. In such cases, we need some objective criteria, so we do this sleep study. Here, monitors are applied like EEG, ECG, ECOG, snoring, recording, sounds, heart rate. All these 12 leads are applied, and this gives index for apnea and hypopnea during an 8 hour of sleep study for the child. Uh, who needs these sleep studies for sure are children less than 2 years who are chronic snorers, certain Down's patients, craniofacial anomalies, some neuromuscular diseases, children with sickle cell diseases, mucopolysaccharidosis. All these children are good candidates for doing a sleep study before they are sent for an adenoid surgery. Also, any discordance in history and examination, we need to advise a sleep study before a surgery is advised. Second test is drug-induced sleep endoscopy. So a drug-induced sleep endoscopy is generally done in the OR, where a BIS monitor is applied with electrodes. This suggests the stage of sleep. So it's kept between 50 to 60 on the monitor. So at that stage, the child starts snoring. If the child is deepened, the anesthesia is deepened, he'll go into a phase of apnea. If it's lightened, there will be no snoring. So it is exactly at this phase when we pass an endoscope into the nose and check for any obstruction. So this is an endoscopy which is done during this drug-induced sleep study. So this is what we see in the nasopharynx. These are enlarged adenoids, almost nearly completely obstructing the nasopharynx. This is a tiny opening which allows the endoscope to pass. This is a very small endoscope. So the choana is completely blocked. So in cases where we are doubtful about whether a surgery needs to be done or the patient has any other associated comorbidities, then we do advise a sleep endoscopy before undergoing the surgery in such cases. So this is also another example where when an endoscope is passed, we see both the tonsils and the lateral oropharyngeal walls are squeezing in during sleep. So this is where we would recommend a tonsillectomy along with adenoidectomy for this child. What extra information does this give? So when we examine the child orally, we only see the lateral part, the medial portions of the tonsils coming into the oral cavity. We do not see the superior pole. When the child is asleep, the superior pole actually comes closer and superior and obstruct the posterior part of the nasopharynx and the lateral part, which is not directly seen on examination, but it is very evidently seen on DISE. So in these cases, we would advise adenoidectomy along with tonsillectomy. So now, if I have to give you in a nutshell, what are the changing trends in treatment criteria? So one would be obstructive sleep apneas. Any AHI, apnea hypopnea index of 1 in a child is also significant. The child should not have even a single episode of apnea during the night. Any child presenting with AHI of above 10 is a definite criteria for surgery. Chronic snorers, mouth breathers who have associated symptoms of otitis media, rhinosinusitis are all good candidates for adenoid tonsil surgeries. Now, recurrent sore throat has come down into our indications, but it still remains one of the important criteria. Age, if somebody asks me what is the right age to do this surgery, it can be done as early as 13 months if it is leading to cor pulmonale or respiratory, significant respiratory distress. So some parents would come and ask, nearly all would come and ask us and the pediatricians, aren't tonsils and adenoids important for my child's immunity? So what our explanation and the thought process going around in the ENT circle is that, yes, we believe that these are security, tonsils and adenoids are the security guards of your patient's child's body. But now at this stage, the security guards are themselves acting as thieves and they are entering into your house and stealing your child's sleep. So it's better to change those security guards, remove them out, and enroll some other mechanisms of safety or guarding, which will help the child to grow better and sleep better. So this is how we explain the parents that these tonsils and adenoids are not useful but counterproductive. And there are other methods of measures of immunity in the blood like T cell, B cell immunity, which will help the child to prevent infections. And it will definitely help in better growth and development in your child. So this is the logic behind early tonsil adenoid removal if they meet the criteria. So nowadays, this surgery is done by this different tool called coblation assisted tonsil adenoid resection. This is endoscopic guided, so it ensures complete removal of the whole of the tissue. So chances of recurrence are very low. The bleeding is also less. Now, tonsil surgery is also being done with this same instrument, and the initial method of removing the whole tonsils, which is the extracapsular in surgical removal, is now being changed to a partial removal or removing only the obstructive part and leaving behind some tissue in the bed, so that there are less chances of bleeding and post-op pain. So this is the changing trends from ENT point of view. This coblation assisted surgery would mean no bleeding because you're doing it endoscopically under vision. There's less post-op pain. The child returns back to school early because he starts eating, playing well, and there is no recurrence in this. So this is the preferred method of doing the surgery. Now we move on lower down from throat to go to the larynx, where the child would present with noisy breathing and stridor. So for understanding any child who presents with us, we need to first hear that sound of obstruction, which can be either a stridor, stutter, or wheeze. Then we have to look for signs of respiratory distress in this child because we need to know how rapidly we have to act. We have to see the grade of distress for this child, whether this child is stable enough to be seen in the OPD and managed in the OPD, or needs immediate referral to an ENT or airway person, or he needs immediate ICU, PICU admission. So we need to see all these three S's and finally give the fourth S, the solution. So we start with the sounds. So stridor is this typical sound that we hear. So it's a high-pitched, harsh sound produced by turbulent airflow in a partially obstructed supraglottic, glottic, or subglottic trachea. While we compare it to this, so this is strutter. I'm sure many of your patients would show you videos of child presenting like this. So these are low-pitched inspiratory sounds caused by obstruction above the level of the larynx, that is nose and nasopharynx, typically snoring or stutter caused by adenoid hypertrophy. Now, wheeze is something that...
Anju, one sec.
Yeah.
Sounds is not clear. Even like stridor or this stutter, both the sounds we cannot hear.
You cannot hear. Okay. I'll try to play again.
You are wearing headphone or it is a computer mic?
Yeah, I'm using computer audio. So there is no audio.
No.
I'm sharing computer audio. I mean, okay, I'll see whether next few slides they have some audio or not.
Yeah.
So, or I can tell you how it is so that I don't waste time. So, stridor is typically this kind of sound. So, it's a high-pitched, harsh, inspiratory sound presenting when children present with obstruction at the laryngeal level. By snoring or stutter, we all know we have seen many children around us with snoring. It will be the sound of the palate or fluttering. So, this is a sound of stutter. And wheeze is audible with a stethoscope, and you are better people to guide us with your stethoscope because it's a high pitched, continuous, coarse whistling sound because of an expiratory lower airway obstruction. Now, here I would like to add one more slide, which is auscultation of the neck for stridor. So, this is sometimes missed by many of us. We do not auscultate for stridor on the neck, on the anterior neck wall. We try to listen to the chest sounds, which are usually conducted sounds from the neck. So if we put a stethoscope on the now henceforth, if we try to put a stethoscope on the neck, we'll able to see this hear this amplified sound of stridor. So what I would teach my colleagues and others who want to learn how to you do this is first check on yourself and then check on the child's neck, and we'll be able to make that difference of normal breathing versus an obstructed breathing. So let's see whether these play. Do you hear the sound?
No, Anju, no sound.
Okay. Can somebody tell me how to?
Ma'am, when you share this presentation, at the beginning only there is an option, share sound.
Okay, let me stop
So what you do is
sharing
you
and
reshare, and then in that you select on the Zoom, share the sound.
I log out and log in again.
No,
No,
don't
no, no,
log
no.
out. Just
First,
do a repeat screen share.
yes,
Okay.
share screen,
Yeah.
and below in left
okay,
corner
yeah.
you will say see share sound.
Okay, yeah.
Yeah.
Okay, are you seeing my screen now?
Yeah.
Yes, ma'am.
Yes.
Okay, now let me know.
Now it's
Perfect,
audible.
ma'am.
Yes, yes.
So if you don't mind, then I'll just play these
Just increase the volume on that.
two sounds also. So my volume is maximum. Are you hearing this sound?
Yes,
Yes.
ma'am.
Yes, yes.
Fair enough.
Yeah.
Fair enough. Fair enough.
Yeah. So there are other videos I believe you'll be able to hear better. So here is this inspiratory sound. With retraction. So any inspiratory stridor typically starts at the level of the supraglottis or glottis. A biphasic stridor would be a little lower down, which is so these are both examples of inspiratory stridor. And any expiratory stridor would arise from the distal airway. Then second step is to recognize signs of respiratory distress in terms of tachypnea, nasal flaring, retractions, grunting, seesaw breathing, head bobbing in children, stress response, and respiratory failure. Once we've seen the child, heard the sounds, and then we see how the child behaves. So there are two different situations. This is a playful child wanting to talk to the mother, smiling, but has a noisy breathing. Whereas this child is in the ICU setup with severe retractions, So our response in both the situations have to be different. Because if this patient comes, similar patients come to the OPD, we'll have to have a different response. So this is by quickly grading the distress in our mind by looking at the child. In all the three situations, there is some noisy breathing with mild to moderate or severe retractions. The sign which differentiates is in grade 1, there is no anxiety, the child wants to play. In grade 2, there is anxiety, restlessness, refusal to play, and not interested in playing. In grade 3, which is actually ominous, where the child is completely exhausted, all his efforts are being wasted into breathing efforts, there's complete refusal of feed. The change in the color and the slowness in the heart rate and respiratory rate, these are the ominous signs where we have to really quickly take the child to the ICU and try to give immediate resuscitative measures. So the first thing that anyone would think of is giving oxygen, because oxygen is life. In all the three situations, you start with giving oxygen, but in the first grade, you have a lot of time to refer the child where the ENT or airway person can evaluate the child, do a flexible or rigid exam in the OR. In the second variety, we don't have that much of time. Oxygen can be started because this is a stage where there is some impending airway compromise, and if not acted quickly, then it may result in some catastrophic event. But we still have time here to evaluate the airway before intubating this child. In the grade 3 variety, which is a dire emergency, if such a child enters the OPD, immediate oxygen has to be started. If there are measures sufficient enough to start on CPAP or push him to the PICU, then that should be done. A quick endoscopic evaluation, if the child has already been intubated, then we would do through the endotracheal tube by withdrawing it. Or if there are no methods of evaluating, then we will have to do a tracheostomy, but we would still try to examine the upper airway to see what is going on. Here, there is a role of immediate cricothyrotomy or percutaneous thyrotomy without doing endoscopy, which all the pediatricians, PICU people, in fact, all physicians, all clinicians should know an immediate cricothyrotomy, but it is recommended only above the age of 8 years. Below the age of 8 years, the membrane is not well developed, so this does not come as an option to us. Sometimes we are lucky, but the patient is unlucky that they present with a tracheostomy tube to us. So as ENTs, we have a lot of time to evaluate the airway. The child is stable. So I'll see how we evaluate. First, we start if we have time, then we would take a detailed history like this. Acute onset respiratory distress, we would think of foreign body aspirations, infectious diseases. Long duration, we would think of laryngomalacia, webs, and stenosis. Then, based on the position situations, we would ask the parents whether it worsens on crying, whether it worsens in supine position, which will indicate laryngomalacias, tracheomalacias, or tongue-related issues, microglossia, micronathia. Whether it worsens at night, then it's some viral croup. Whether it worsens with feeding, then we have to think of laryngeal clefts, tracheoesophageal fistulas, malasias, vascular compressions, those problems. If there's an antecedent upper respiratory infections, then we know that this is croup or tracheitis. If there's a choking episode, then the parents usually then will tell you that their child has eaten something and he's choking, so it's a foreign body thing. Associated symptoms like barking, cough, drooling, weak cry indicates laryngeal pathology. Muffled cry would indicate a supraglottic pathology. Hoarseness is typically, we know that it's a laryngeal issue. Snoring, we have discussed that it's adenoid or tonsillar issue. And dysphagia means a supraglottic problem. Now, past health is also important to be discussed here, and any history of endotracheal intubation presenting to us after 4 to 6 weeks of extubation is very important, that it may be vocal cord paralysis or fixity, or it may be an impending laryngotracheal stenosis. And these cases are on a rise because many NICUs, PICUs are now sending the patients off after a good period of intubation. They are now getting extubated. So these patients now come to us with stridors after 4 to 6 weeks due to these problems. Now, any history of birth trauma, perinatal asphyxia or cardiac problems, neuro problems, you think of cord palsy. Atopies, you think of angioneurotic edemas or croup. Then Downs, hypothyroidism, family histories for psychosocial disorders, all will lead towards a diagnosis. Then we try to examine this patient when the child is stable, whether there is any cyanosis, fever, toxicity, tachycardia, bradycardia, all pointing towards specific diseases. Then the stridor, which we discussed, inspiratory, expiratory, biphasic. By just looking at the child and hearing the sound of the stridor, we can precisely locate the origin of the problem. Position of the child is important. With hyperextension of the neck, we know that there is an extrinsic obstruction above the larynx. So that's why the child is keeping that position to keep his airway open. If he is leaning and drooling forward, it's epiglottitis. If the child is improving in prone position, then it's laryngomalacia. On auscultation, if you get an inspiratory loud sound, and of course not just chest, we would also like to examine on the neck, then it will be a laryngeal obstruction. Prolonged expiratory phase means a tracheal obstruction, and one-sided decreased entry we all know is foreign body aspiration. Now, certain associated signs like cutaneous hemangiomas are very classical of subglottic hemangiomas. So we have to examine the entire head and neck region of the child. If there are any facial hemangiomas, it points towards a subglottic hemangioma problem. Neuropathies and edemas may point towards respective pathologies. So this is a very good chart that we refer to and ask our pediatric colleagues also to see if the stridor if the child presents with severe stridor, then of course we have to give immediate resuscitative measures. But if the child is stable, like all of us see in the OPD, if it's an inspiratory stridor or snoring, then it's a nasal supraglottic problem. If it's a gurgling muffled sound, then it's usually pharyngeal problems with tonsil adenoids, large tongue, tonsillitis, epiglottitis. If it's high-pitched inspiratory voice changes, then laryngeal problems. If it's lower down, then you will have wheezes and sounds, stridors, then it's a tracheal problem. And then finally, your field, your domain is that bronchial asthmas and obstructed airways. So now when such a child comes to an ENT or an airway person, how do we evaluate? So this is a picture of a plumber who is using a very primitive endoscope, going into a tiny pipe and seeing what is obstructing. So we have kind of taken that same principle, though we do it in a little more polished way. It's called an awake transnasal flexible fiber optic laryngotracheoscopy. So this is a flexible scope that goes through the child's nose, and we are giving oxygen through an endoscopy mask. We can also deliver sevoflurane and check for collapsible structures like the dice that I showed. And the third examination is direct laryngotracheoscopy under general anesthesia, where we use your intubating laryngeal intubating Macintosh laryngoscope or a Phillips blade in small children, and a 4 millimeter rod endoscope to examine the airway from the oral cavity up to the carina. So this is how we examine the patient. And different pathologies that we find during our examination, which most commonly in the neonatal period would be laryngomalacia, which you all would be interested in. It is the floppy tissues of the voice box that drop into the airway when the child breathes in. Symptoms usually are inspiratory stridor. Now here, you should notice that it starts after the first 2 weeks of life. So any stridor that presents immediately after birth need not be necessarily laryngomalacia, because the history typically starts after 2 weeks. It increases over the next few weeks to 6 months, and then the laryngomalacia stridor starts reducing. So we have to notice all these histories: difficulty in feeding, choking episodes during feeding, acid reflux, poor weight gain, child stops bleeding during feeding episode, and bluish skin color or cyanosis. These points towards laryngomalacia. As we all know, 90% of these cases would get better without treatment in 18-20 months of age. But who are these children who really need treatment? I would say that all these children who presents with laryngomalacia at least need a chexcopy without anesthesia, which I showed you. It's a flexible scope which passes through the nose, because there are many pathologies that we see endoscopically which are surgically correctable, and we don't have to wait for such a long period of time. So this is type 1, which is floppy arytenoids. This is type 2, where the airy epiglottic fold is very short, and one small cut over these two will open up the epiglottis like a fan, and we will be able to see the vocal cords very well. This is a floppy retroverted epiglottis. So these are pathologies which we assume will improve with time, but actually they will not, because these are actual pathological structural problems, not just collapsible airway. So I would like to show the video because that will create more impact. So these are the two vocal cords. And if you see, the arytenoids are flopping in with each inspiration. Even if we wait for 6 months for this child to improve, there will be hardly any rigidity achieved in this kind of floppy arytenoid. And a small procedure called supraglottoplasty, or reduction of these prolapsing arytenoids, would result in dramatic improvement. Now, in this case, this is type 2 laryngomalacia, where you see the epiglottis is tubular. And one small cut on these AE folds will open up this epiglottis and breathing will become much easier. In this video, you see this epiglottis prolapsing with every breath inside. So this does not gain rigidity even after waiting for several months. So such children, if we do a simple endoscopy and try to diagnose it, we can give good results. So what is the criteria for surgery for us? This is a common question asked by pediatricians. So we see if there is severe stridor with obstruction resulting in hypoxia or hypercapnia, then definitely we cannot wait for such a child to outgrow the problem. If there are associated feeding difficulties or failure to thrive or any persistent stridor after 6 months, we need to do a chexcopy and most probably we'll be able to give a correctable result to the child. Obstructive sleep apnea, when it is associated with laryngomalacia, will result in severe hypoxic problems to the child, and so these two conditions have to be diagnosed early in life. Chest deformities, which means chronic obstruction, and pectus means the child has been breathing like this for a long time, indicates that this is not going to improve on its own. Cor pulmonale is a definite criteria for surgery for us. So all these has to be kept in mind when you see a laryngomalacia child in the OPD. I'm not saying that every laryngomalacia child will need surgery, but if we are aware of it and we know the risk factors, then at least they will be referred for a simple laryngoscopy. The second most common cause of stridor in a neonatal period is subglottic stenosis. So the symptoms usually are stridor, breathing difficulties. Sometimes they also present with recurrent croup or barking cough, and at times we have seen that they are being treated like asthmatic patients because every time they have an attack of URI, the steroids would work on them, the nebulizations would work on them. But I would like to give one example of such a case. So this is this 5-year-old male child with chronic cough, biphasic stridor only during attacks of upper respiratory infections. Otherwise, he is a very healthy child growing very well. So when we did this endoscopy, we see that the cords are edematous, there are vocal cord nodules developed, and he has a significant narrowing in the subglottis. This is to the grade of almost grade 3, early grade 3, which is 50 to 75% to 90%, 99% of obstruction. So in such cases, we definitely have to do an endoscopy. So as I said, any stridor which does not improve with time has to be checked with an endoscope. So then we grade the stenosis, and based on the grading, we would do the treatment. So grade 1 and 2 are early grades of narrowing, which can give good results with endoscopic treatments. Grade 3 and 4 are obstructive lesions and tight stenotic lesions, and open surgical procedures are needed for them. So this is one more third example, which is a cord palsy, which is very common in pediatric neonatal age group. This is a 3-month-old child with severe
Anju,
intercostal
ma'am,
retractions. Yeah,
sorry to interrupt. We can you remove that bar on the top of the presentation? No.
yeah,
Just click on that slide. Presentation. Just click on the presentation.
I'm clicking. Now I'll have to hide the notification.
Yes.
You are also seeing it.
Yes, ma'am.
This is okay.
It's still there.
I'm not seeing it now.
Yeah, it
Yes,
is okay.
ma'am.
Yeah,
Yes,
it is
ma'am.
okay now. Yeah.
Yeah.
Yes,
So
ma'am.
this is okay. This is a 3-month-old child with severe intercostal retraction and inspiratory stridor. She was operated for fistula at birth by pediatric surgeon. So if we see this video, so we see the normal two vocal cords, but they are not lateralizing. They are adducting and trying to create closure, but they are not abducting very well. So this is a case of bilateral abductor palsy. The treatment options would be suture lateralization, which is an endoscopic procedure where we pass a suture from one vocal cord out into the neck to lateralize the cord. Or we can do an endoscopic cricoid split, which is again done endoscopically. We cut the cricoid, insert a balloon and expand it, or we can do a laser arytenoidectomy as the child grows. And of course, the option of tracheotomy remains because sometimes this can improve with advancing age. We can wait up to 3 to 4 years with a tracheostomy in bilateral abductor palsy if it is not a iatrogenic lesion. If it's a congenital lesion with no neurological complaints, then tracheostomy is also a good option for these children if the parents are well trained to take care of the tube. After the age of 3 to 4 years, 80% of the children will not show any, 80% would have improved and 20% would still remain with that. After that, we can do a definitive treatment for these children. Then we can sometimes find on our scopies these webs. Like in this case, this child was operated for TO fistula at birth with multiple procedures and repeated dilatations for the dehiscence of the gastrostomy. After every extubation, the child presented with stridor. On doing a scopy, he had this kind of web between the two vocal cords, along with a narrowing in the distal airway. So these kind of things are missed frequently because the scopy is not done. So here again, all these post-extubation children with voice problems need to be scoped early. Now we also find these hemangiomas, which I mentioned earlier. So these are vascular lesions, sometimes unilateral, at times bilateral. They can completely obstruct this airway, but they are collapsible and they can be intubated. And the magic drug that has come up for these is propranolol. Propranolol can be given in oral form as well. Initially, we can give injectable, then taper it down as the child responds. So this does not require surgical intervention. We wait for 2 years for clinical response. If it does not, then we have to remove it if the child is still obstructing. We have certain cysts presenting with like these. So the child is presenting immediately after birth. On endoscopy, this is a large valvular cyst. So the treatment of this valvular cyst is simply marsupialization or just uncapping the cyst and removing all the fluid. And immediately after the procedure, the child remains stable, can eat well, and there is no stridor. So all these can be presenting features in the early neonatal period. Now, certain patients present with cleft. So these are rare anomalies, but as a pediatrician, everyone should be aware of these problems. These children present with feeding difficulties, failure to thrive, and an inspiratory prolapse of the mucosa. I'll explain the video. So if we see, there are two vocal cords here, and there is a mucosa coming in between. So it seems like there is a polypoidal tissue here, but it's actually the pharyngeal mucosa that is prolapsing into the airway because there is a laryngotracheal cleft. So when we see while relaxing the child, we see that the cords look okay. As we go inside, this is a deep cleft. It's a type 2 cleft which has split the cricoid as well. So whatever the child eats goes into the airway. So these children will have feeding difficulties and stridor. So these things have to be diagnosed early in life because treatment is endoscopic repair, which can be done easily with or without a tracheostomy. Now, trichomalacia. Trichomalacia is a common problem I believe many pediatricians would see in their OPD. Trichomalacia is when the posterior tracheal wall or the membranous trachea collapses into the airway. These children usually present with stridor, sometimes recurrent respiratory infections because they are not able to cough out these distal secretions out. An endoscopy to just find out how much is the obstruction will help us because if it's less than 50%, then we don't really need to treat this. We can wait and watch for the child to outgrow this problem. If it's more, then it will require some kind of CPAP. And then later on, if it doesn't improve with time, then a tracheotomy and surgical correction. So diagnosis is very important in these cases. Then we move on to the acquired conditions. So this is an example of a post-intubation stridor. We were called to do a tracheostomy, but before the tracheostomy, or maybe if the child is not stable when we do a tracheostomy, we always check this airway. When we go inside, we see there is this intubational injury or a granuloma developed because of the tube. The cricoid inside is eroded, and we see the mucosa all exposed. The cartilage is exposed. There is perichondritis. What a simple procedure like removing these granulations and apply endoscopically steroid over this local area and re-intubating with a smaller size tube or maybe doing a tracheostomy if that is clinically needed will solve the problem uh, will solve the problem immediately. So this is what we are now recommending to many of our ENT colleagues that all patients who are called for a tracheostomy should actually undergo um, I'm sorry. So all patients who are called for a tracheostomy, we should try and remove the endotracheal tube and check for the airway. Can you see my presentation?
No, madam.
No, madam.
Just Microsoft. Now, are you seeing my?
No, ma'am.
Just a second. Yeah, now it is.
Yes, ma'am. You just need to share this.
Yeah, full screen. So this is what we recommend for all cases who are taken in OT for a tracheostomy. We should check endoscopically and remove these granulations and apply steroids. So when we check these patients after 8 days, we see magical clinical response. See, the vocal cords have healed very well. The granulations have gone. Subglottis has healed very well. So this is a simple procedure can lead to dramatic results. This is another example of a child presenting with uh, who was operated for TO fistula at birth. Multiple intubations were done for dilatation, and he developed this kind of glotto. These are the two vocal cords. So glotto subglottic narrowing, grade 3 narrowing. With he needed a tracheostomy for the same. He for these kind of problems, we'll have to do a double stage cricotracheal resection. So these are problems that we need to try and anticipate early and try and do surgical correction. So this is after the surgical correction, we see a good airway and the child gets decannulated. Now, bilateral cord palsies were many patients who are intubated for a long time. They present to us like this. So this is we see that this is bilateral cord palsy. But when we check them under anesthesia and give relaxant, we use a vocal fold retractor. So here, these in this case, if the vocal cords get retracted nicely, it's vocal cord paralysis, not fixity. While in this video, you will see when I put this vocal fold retractor, they will not get separated. So this is called this is cricoarytenoid joint fixity. So those are two different entities which we will be able to diagnose only if we do an endoscopic assessment under anesthesia. Now, certain patients who come to us with these kind of pictures, these are more pediatric cases coming to the pediatricians. This is acute epiglottitis with high grade fever and severe inspiratory stridor. So there is no role of any surgical intervention, only IV antibiotics, steroidal nebulizations, humidified oxygen, and hydration will result in dramatic improvement. Now, retropharyngeal abscess. So if we see these patients present with odynophagia, this child had history of low-grade fever for a long time with Cox contact. On the X-ray, if we see the shadow, this is the shadow of the airway. This is the shadow. This is the pre-vertebral shadow. So we see that the pre-vertebral shadow is increased, which suggests that there is a collection in the retropharynx. When we try and see them in the with a laryngoscope, this is a video laryngoscope. There's some foreign material here. This is the bulge in the retropharynx. We see the cords. We try to intubate under vision and then take a nick over this bulging area and drain all the pus and send for culture. And this came out to be uh, Cox actually. So this is how we can diagnose certain conditions like retropharyngeal abscesses who present to pediatricians first with odynophagia. Now, foreign bodies. These are typical in that age group where they present with some history of ingestion and then sudden coughing and then the child becomes silent. So any foreign body with the child can pass below the glottis and it goes down easily and goes into the bronchus. This is not an emergency, but a foreign body like this, which is struck in the mid-tracheal region or at the level of the carina, is going to present with severe respiratory distress, and there is no time for us to really evaluate. We have to take this child immediately to the OT and use a rigid bronchoscope to remove the foreign body. So these are real emergencies presenting to the pediatricians, and they have to rush these patients to a very specialized centers who have all the equipment to remove these kind of foreign bodies. Now, external laryngeal traumas can also present to us. Certain children, when while playing, I've seen children were injured with the balls or cricket bat, or sometimes even while running, if they trip and they fall, there is direct injury on the neck. So the classical sign is any contusions or bruises on the neck with change in voice is an indication to do a laryngoscopic examination and a CT scan, because they may present with fractures of the thyroid cartilage and cricoid cartilage, which we do not realize until they present with stridor to us. So any child presenting with a history of direct trauma to the neck with change in voice without respiratory distress initially, but has bruises over the neck or some emphysema, is to be treated like an acute fracture of the femur or any long bones. It has to be treated immediately, taken to OT, intubated, and these fractures of the neck has to be repaired immediately. So lesson to be taken from this slide is children presenting with trauma to the neck have to be referred immediately. Now, these children with present with hoarseness, they might come to pediatricians with some hoarseness and inspiratory stridor. When we do this chexoscopy, these are grape-like structures in the scene arising from usually from the vocal cord or supraglottic region. These are papillomas. So papillomas are treated by simple endoscopic removal using lasers or debriders. We try to preserve the vocal cords in these cases. Uh, you, are you seeing this next slide?
No. No, ma'am.
No, ma'am.
No, ma'am.
Okay. Oh, because it has too many videos, it at times. Sorry for this.
Mm, 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 mm.
Now it's see.
First slide is visible.
Yeah.
Yeah.
Yes. I now are you seeing that this now? Are you seeing the papillomatous slide?
Yes, yes.
Okay, so this as I'll show it like this, maybe yeah. So after removing these papillomas, we'll be able to see the vocal cords very well. So in these cases, the aim of the treatment is just to remove the papillomas, not injure the vocal cords. So this can be diagnosed easily but if the patient presents to a pediatrician with hoarseness, they know that it's a vocal cord problem and this needs a laryngoscopy. So the next is uh, such a child who presents with a tracheostomy to a pediatrician. So here, the role of a pediatrician would obviously just be to understand and make the parents explain about the care of tracheostomy. So the first important thing that they need to know as parents would be that the tube has to be, the PVC or the Potex tube has to be changed every 28 days. Otherwise, it becomes infected or blocked. The silicone tube, which is the soft variety of tube or the white tube, that can be kept for 9 months. There is this video link where this is a video made by me on a patient where I've shown how to change the tube, how to suction the tube, how to keep the tracheostomy tube. You can all go to the link and check this out. But basically what it covers is cleaning of the tube. For cleaning the tube, if the parents are trained to check the blast at all times. So if a patient comes to you in the OPD, you check the blast whether the tube is blocked or not. Try to suction the secretions well. You can clean the tube with sterilium or any hand rub with a gauze piece, or you can use that cotton bud to clear the whole area. In case of a blocked tube, the parents have to be told how to check, how to suction the tube, check the air blast. If it's not improving, then you put some soda bicarb and resuction. Nebulize the child well with saline nebulization and then try to resuction. And if it's not happening, then we have to replace the tube. Now, this care of stoma or infection control is very important for all of us. Proper hand washing, gloves, daily changing of dressings, change the neck straps if the child comes at least once a week, because they usually get soiled while bathing and all. If we see any granulations or redness around the tube, then we need to apply ointment using a cotton bud. Steroid ointment can be applied, like gentamicin, clobetasone, or Kinacort can be applied. And if you feel that the tube is getting infected, then a swab can be sent for starting systemic antibiotic. Now, humidification has to be maintained all the time because the child is not breathing through the nose. So the role of nose is being done by the tube. So either we keep a humidifier or we keep a wet gauze over the stoma all the time so that the child, the secretions do not dry out. Another thing is for changing the tube, pediatricians need to train themselves. Now there are workshops for pediatricians. They can train them on dummies so that in an emergency, if a child lands up with a blocked tracheostomy, they know how to change it. In that video, it is shown. I can share the link with your group. Uh, how does the child communicate with the tube is a common question. So if it's a cuff tube, we'll have to first wait for the tube to get deflated, and uncuffed tube with a smaller side has to be put. And there are speaking valves available on the tubes which can be used, which can help the child to phonate along with the tracheostomy tube. So key points that the caretakers have to remember, that whenever a child with trach is there at your house or in your clinic, you should have a same size tracheostomy tube or a smaller size ready by the bed of the patient. You should always keep a bell. If it's an older child, he can ring the bell and call because he's not able to talk, or give a narrator valve if it's possible. In case the tube dislodges, you should not panic. Just try to extend the neck of the child. Stretch the stomal skin with your thumb and index finger as I am showing. If it's a long-term tracheostomy, the child will be able to breathe nicely through the tube, through the opening. Meanwhile, you can arrange for another tube and try and insert this. If the child cries and flexes the neck, that is the time when we lose the airway and we are not able to pass the tracheostomy. So these are small points that everyone, all clinicians should know to avoid dire emergencies. And of course, in an emergency, always have your local ENT or airway person ready so that you can refer this child immediately before something bad happens. So to conclude my whole presentation, so tonsils or adenoids now are not just considered benign lymphoid tissues anymore. They are actually part of that obstructive sleep apnea spectrum, and hence they have to be treated as a different disease now. And management protocols have changed, and pediatricians have to be aware of it. Seeing is believing, hence we believe that a flexible laryngoscopy is must for any noisy breathing child. It does not require anesthesia. It can be done under local anesthesia up to the level of vocal cord. Of course, beyond that, we'll need some kind of anesthesia. Uh, Tracheostomy is not the solution for stridor. It is just a bypass. The problem is above the tube. So once we put in a tracheostomy, we will not know what was happening above the tube. So we have to try and avoid doing tracheostomies. First, try and do an endoscopic examination. Care of tracheostomy has to be learned and taught to everyone around you because it is life-saving. It's just like how we have CPR training. Similarly, tracheostomy care training has to be given to all the clinicians around us. Thank you so much. I'm sorry for the technical glitches. I hope I've conveyed my points. I'm happy to take any questions.
Thank you, Dr. Anju. The presentation was very self-explanatory, so I guess somebody is having the question.
It's okay. If there are any questions in your group later on, you can pass it on. I can happily answer those questions on WhatsApp.
Yeah, yeah. So I request Dr. Ajay Kohli sir to give please vote of thanks. Hello.
Dr. Parvez?
Yes, sir.
Thank you, Dr. Parvez. First of all, I would like to thank our speaker for today, Dr. Anju ma'am, for a very comprehensible and in-depth session regarding the most common problems which is faced, that is the respiratory disease problem. She has given a very wonderful and in-depth information on almost every possible topic regarding that. Thank you, ma'am, for the wonderful session. Next, I would like to thank our moderator for the session, Dr. Parvez, sir. Thank you. And our president, Dr. Vikas More, sir, for organizing and executing such a wonderful and very important and relevant session for today. And last but not the least, I would like to thank all the people who have attended from the Zoom link as well as who are attending from the YouTube link. Thank you, everybody. With this, we come to the end of the session. Take care. Thank you very much.
Thank you so much for the invite.
I thank you, Parvez, for bringing Anju madam to IIT.
Yeah.
Yes.
Thank you, everyone.
My
Thank you,
pleasure,
IIP
sir. My
Raigad.
pleasure.